All right, well, thanks. That was a nice introduction. Thanks, Chris. So today I'm going to talk about pulmonary ultrasound, and this is a relatively new field, although in Europe it's been going on a lot longer than we've been doing it in America. There are actually some intensive care units in Europe who don't use chest x-ray for very much at all. They use ultrasound to look for pneumonia, pneumothorax, line placement, endotracheal tube placement. They use ultrasound for all of that. And it's just now catching on here in America in the last, say, decade, that we understand that you can actually ultrasound the lung. The prior understanding, and I know all of you have had this multiple times, is that air doesn't transduce ultrasound well, so how could you possibly ultrasound image the lung? Well, what I'm going to teach you today is that we don't so much look at the lung as we look at the artifacts created by the ultrasound waves that travel through the lung. And that tells us a lot about what's going on with the underlying tissue. So there's a classic differential diagnosis that we see all the time. You will see it your first time in the hospital. Somebody presents short of breath, and the question is, what's going on here? So if you have a patient who's 56 years old, who smokes, who has a bad heart, and the differential is wide, but it definitely includes at the top of the list congestive heart failure and COPD exacerbation. So that's always the clinical dilemma is, which one is it, congestive heart failure or COPD? And historically, we didn't have a good way of knowing, because sometimes the chest x-ray is not, adequate to tell us which one it is, and sometimes it can be both, because patients are allowed to have two diseases. So sometimes we don't know how to treat these patients, and what we've done is we give them medications for the CHF, we give them medications for the COPD, and we hope something sticks, and we hope it works. But it is very powerful now that we know how to use ultrasound to be able to focus what we do and actually give them the therapy that is directed at what the underlying problem is, instead of just shotgunning the therapy. So the lung ultrasound is very much based in evidence. There's a big body of evidence now and it's growing on how we can use ultrasound for imaging the lungs. We know that chest x-ray is inferior, and in other words, ultrasound is superior to x-rays for differentiation of CHF from COPD. There's several other things that we know from the evidence, which is we can adequately look at alveolar interstitial syndromes, which in other words is pulmonary edema and variants of that, pneumothorax, pneumonia, COPD, pleural effusions, hemothorax. I can read you the list, you can read it yourself. But not only can we appreciate diagnoses on ultrasound, but we can also guide our procedures and our imaging during procedures to increase patient safety. All of this has been well worked out. There's some key probe positions which you'll be practicing today in your practical sessions, but it's also a good habit to get into to look at all 8 key probe positions on the chest. There's 4 on each side. And in what we're looking at, if you delineate the chest as far as the sternum, the anterior axillary line, and the posterior axillary line, divide up the chest into 4 areas on each side. And you want to look at a representative area in each segment so that you can feel like you've had a good overall picture of what's going on with the chest. This patient is lying down. Most of the patients you'll see in the hospital are lying down that we ultrasound, although it is possible to image the back. And what we're teaching you today is primarily we focus on the anterior, because there are there's gravity, and essentially if you're on your back for any length of time, any kind of fluid in your lungs will go to the back and you'll get false positives. So we really want to image the front and the sides to tell us what is going on in the lung. Anteriorly is the best place to look for pneumothorax, and we'll talk about that in a few minutes. But if you think about it, if you're supine and you have air that has escaped from inside the lung into the pleural space, where is it going to be if you're on your back? It's going to be anterior, right? And posterior laterally, we can best see effusions, which is fluid that's in the pleural space, and consolidations, which are pneumonias or atelectasis of the lung, posteriorly, because those are gravity dependent. All zones, though, you can appreciate pulmonary edema. Pulmonary edema in very rare circumstances will be unilaterally, but in most cases, this is due to congestive heart failure or a non-cardiogenic pulmonary edema. It's going to be bilateral. And so you should be, when you're trying to identify pulmonary edema, being able to see it in multiple fields. Very briefly, the probe selection, ideally we use the curvilinear probe, but it depends on your patient's body habitus. You can use the high frequency linear probe, and you can also use the cardiac probe. A lot of it depends on whether you're looking for the forest or the trees. If you're going to look for the big picture, you start with the low frequency probe that gives you a deeper view. And then when you're looking for the detail, like we do when we look at pneumothorax, then you pick up the high frequency probe and you get more detail. So you'll see examples of both of that. A couple quick tips, and this is important for any kind of imaging, is if you don't have a great picture, if you don't see anything, basically you have to think about, well, what troubleshoot. Do you have enough gel? Air is your enemy, gel is your friend. You've probably heard that 1,000 times, but it is absolutely true. If you don't have gel, or you don't have good contact with the chest wall, or if you've got something obstructing in the way, you have a bandage or a bra strap or something like that, you need to clear those things so that you can see. You may need to reposition the patient. And you also have to consider, is the reason you can't see anything is because there's air in the tissues or air in the thorax, like a pneumothorax, and it's obliterating your image, and that tells you something too. So looking at the overall picture is important. Very quickly, I'm going to review lung anatomy. I know you've all had this on histological and gross levels, but the lung is divided, and we're really interested in what's at the periphery of the lung. The terminal bronchioles branch into the alveoli. These are divided off from each other in interlobular septi. And so if you look at that histologically, this is a normal lung. You see the terminal bronchiole and all of the little alveolar sacs off the end. This is what it appears like in pulmonary edema. So you can see that the air is replaced by fluid. You'll also notice that the interstitium in the picture of pulmonary edema is quite a bit thicker than the interstitium in a normal lung, and that's going to be important to note. Looking back at the picture, the pleural line it is also sometimes referred to, you'll hear it referred to as the VPPI, which is the visceral parietal pleural interface. It basically just means where the visceral, the parietal pleura come together and they move on each other. So these terminal bronchioles go all the way out to the periphery of the lungs, and the interlobular septae come up to the surface in a perpendicular fashion. That is important also to note, because it will explain some of the artifacts we see in a moment. Also, most people, these interlobular septae are about 7 millimeters apart. It's not a key that you understand, and you remember that number per se, but just approximate in your head about how far these structures are apart. So now that you remember what the lung looks like, and we've talked about which probe to use, what you're really interested in is when you're looking at someone's lung, is it normal or not? And the way that we ascertain that is to look for some artifacts that are classic in certain situations. One is A lines and one is B lines, and of course you're asking them what are A lines and what are B lines, and we're going to explain all that. A lines are horizontal artifacts. They're repetitive, they're from reverberation due to ultrasound waves that have gotten trapped at the pleural line. So anytime you have two things next to each other, two substances or tissues next to each other that have a really different acoustic impedance, for instance, pleural line and air right next to it, you're going to have, that sets up a reverberation at that interface. The ultrasound waves get trapped right there, and they reverberate back and forth. And what happens is the probe reads that as a deeper structure. You can see A lines in normal lungs or in pneumothorax, because A just means air. It doesn't tell you where the air is, it just tells you there's air. The air could be in the lung in a normal situation, or it can be outside the lung in a pneumothorax. So to show you what we're looking at here, this is the chest wall. This is obviously a high frequency probe. This is the chest wall, and then you have the ribs. The cortex of the ribs are bright white. The pleural line, or visceral parietal pleural interface, is just below, usually about a 0.5 centimeter below the ribs, depending on the patient's body habitus. And then down here you have this A line, which is just, and I'll take it away so you can see it. You see that reflection of the pleural line deeper? That's artifact. That's not really there. It's the fact that ultrasound waves have gotten trapped in that bright white pleural line that has very different acoustic impedance than the air right underneath it. And it sets up a resonance back and forth. And occasionally that resonance goes back to the probe, and the probe sees, well, the signal took a little while longer to get back, so there must be something deeper that's creating that signal. So you will see these repetitive horizontal artifacts, and I'll give you some more examples. You'll also notice that the A lines are spaced equidistant from the space from the chest wall down to the VPPI is the spacing that you'll see. And if you take a probe or increase the depth, you'll see that that spacing remains consistent throughout. Okay. Another example, just a reminder, the air is just not a good transducer of sound. The sound will reach that pleural line there, and it will just, most of it will scatter back. But the ones that do reach back to the probe in an organized fashion will create an image, and that's the pleural line. However, some of those sound waves reach the pleural line, and they get stuck in the pleural line, and they reverberate, and they reach back to the probe later, and it ends up interpreting that as lines that are lower. Can everybody see that? Mm-hmm. It's just an artifact. Your lungs are not striped. This is because there's air, and the difference between the air and the pleural line is creating this artifact. Okay, so normal lung will have A lines. Also, pneumothorax will have A lines as well. So A line does not necessarily mean normal, but you will see A lines in normal lungs. Yes, you had a question?
Does it depend on what frequency you use, since if it's a resonance effect?
It doesn't really depend on what frequency you use. You'll see this artifact because there's such a huge difference between the acoustic impedance of the pleural line and the air next to it that there will be a resonance phenomenon with most any probe you pick.
Will the depth of the line change or not?
It doesn't change. It's still the same distance. The depth of the line is from the chest wall to the VPPI is the spacing. You'll see multiples of that as it goes down. Okay? Good questions. So when you're wondering whether you have normal lung or not, you were looking for, well, are the A lines gone? Because if the A lines are gone, then that means there's not air there. There's something else has replaced the air in the lung, and that could be anything. That could be blood. It could be edema, infection, contusion, tumor. Any number of things can obliterate the A lines, and then you have to start thinking what has taken its place. So now we're going to get into what are B lines. B lines are actually vertical artifacts that erase the A lines. So the normal aerated lung has A lines, but if you have B lines, these are artifacts created by fluid in the lung that will obliterate the A lines. So normally these vertical comet tails, you can have a couple little ones that are normal. You can have up to 4, some people say 3, can be normal. But if you have multiple diffuse B lines in multiple fields, then that is abnormal. That is fluid that has overtaken the air in the lung. And you remember that histology picture we just showed you with the thickened interlobular septi and the fluid in the alveoli. It could also, that fluid is next to the air in the lung and will create a reverberation, but the reverberation in that case is vertical. And I'll explain why in just a moment. So here's an in-motion picture of what B lines look like. The fluid is replacing the air. It looks like a light show. And you'll notice that there's multiple, and they go all the way to the edge of the screen, and the A lines have disappeared. Another example, these are finer B lines, and there's a physiology behind why these look a little bit different than the others, which I'll touch on. So the reason the B lines happen is, again, it's an artifact that you have to interpret what the artifact is because you can't actually see the lung. The sound waves are trapped in the fluid that's in the interstitium. Remember the interstitial walls, the interlobular septi, are about 7 millimeters apart. When those get thickened with fluid, the sound waves get trapped in that interface and will create a reverberation. And the reverberation is vertical because those septi are vertical compared to the chest wall. They come all the way up to the chest wall perpendicularly. So as the ultrasound beam reaches that interface and creates a reverberation, it creates multiples of this reflection, and therefore you end up with a comet tail. You'll see 2 different types or natures of B lines. One is the more gross appearance, which is what you're seeing on the left there. That is interstitial edema. Generally, that's fluid that's in the interlobular septi, but maybe not in the alveoli yet, but still it's a fluid that's not normally in the lung. And those tend to be spaced about 7 millimeters apart up at the chest wall. The one that on the right that looks more fine and diffuse, that's when you progress from just interstitial edema into alveolar edema or ground glass or more significant pulmonary edema, so that the fluid is actually in the alveoli, and that means the alveoli are spaced only about 3 millimeters apart, so you have just a kind of a diffuse B line. Appreciate the difference there? Okay. All right, so just to review, the key findings when you have pulmonary edema or alveolar interstitial disease, which can be cardiogenic, non-cardiogenic, and it could be fibrosis. There's many things that could create this, but essentially what it is you don't have air, you have something else in the interstitium of the lung that's replaced the air, so your A lines are gone, and then you have comet tails that go all the way to the edge of the screen. They're multiple and in multiple fields. Just a few more examples. B lines versus A lines, the horizontal versus the vertical. And just some stills of different ways that the B lines can appear. Chest x-rays, if you've had any radiology, you'll have heard the term curly B lines. And on a chest x-ray, a curly B line is this perpendicular to the chest wall opacity that represents pulmonary edema. So you can see the B lines on ultrasound and B lines on chest x-ray, same terminology, describing the same thing. So when you later on hear somebody refer to a chest x-ray that has curly B lines, that's a marker of pulmonary edema, and that's what they look like, and so you can imagine why they look the way they do on ultrasound. Okay. We're going to move on. We'll have some time at the end for more questions about A and B lines, but we're going to move on to ultrasound of pneumothorax. And just a reminder about what a pneumothorax is. Normally, your lung is inflated. It's like a balloon. It's covered with the visceral pleura, and the chest wall is covered with the parietal pleura, and normally they're adhered together, usually almost like a suction, a very thin layer of fluid between the two. And if any air gets in between those two layers, the lung will just collapse. You lose the suction. So a pneumothorax is when your lung has collapsed and air has entered the chest cavity instead. Pneumo meaning air, thorax meaning chest. So what about chest x-ray for pneumothorax? You have a patient who's short of breath, you get this chest x-ray, it looks like the lungs are inflated, it couldn't possibly be a problem, right? Loaded question, right? So if you get a CT scan of this same patient on their back, you will notice that on the left side, and remember you're looking from the foot of the bed, the left chest, the lung has separated from the chest wall and has deflated. The upper lobe is completely deflated. You couldn't see that on chest x-ray. It's the same patient who was in that chest x-ray just the slide before. You couldn't appreciate that because when they're on their back, where is the air? Anterior. So if this person is laying down on their back, and they are by definition because this is a trauma film and you don't have trauma patients and C-collars sitting straight up and talking to you, they're on their back on a backboard. You take a film, and if that air has escaped from the lung and is sitting in a bubble anterior to their heart or anterior to their left lung, you're not going to see it. You can't see any line. Direction. So CT scan has really been the gold standard for a long time, but now ultrasound is gaining on that, and it's actually gaining a lot of favor because one, it's cheaper, it's safer, and it's faster. It's a lot faster. So we can very successfully ultrasound for pneumothorax. And so we'll talk about that. And what we're going to be doing is interpreting those artifacts to see if we have normal lung or not. There have been studies, blunt trauma studies, that have compared CT or placement of chest tube with rush of air as the gold standard versus ultrasound, and compared that to how chest x-ray it functions as far as a test. And chest x-ray is not as good as ultrasound. There's some studies that put chest x-ray at a coin flip, 40% sensitive for pneumothorax in the supine position, and some up to 75. But either way, if I was the patient on the bed, I wouldn't want to be in that 25% that they missed. So ultrasound is much better. If you see the lung moving underneath the chest wall, then you don't have a pneumothorax. It's 98%. So the technique that we use to scan for pneumothorax is, we have to remember that the heart takes up a lot of the left chest, and there's no lung in front of that heart in most patients. Some of our COPD are the exception, but most patients, the lung does not go in front of the heart. So you start at the mid-clavicular, you use the high-frequency probe again, because we're looking very superficially, we're looking for the pleural line, which is only a centimeter or two underneath the surface in some people. You choose the high-frequency probe, you start in the second intercostal space. The orientation is towards the orientation marker is towards the head, and you move downwards anteriorly and then splay laterally so that you're getting images in all 4 quadrants. You have to do it a little bit more laterally on the left so that you avoid the heart. What you also want to do is when you put the probe on the patient, you want to watch them breathe through a few respiratory cycles, because what we're trying to pick up here is the pleura moving? So you have the visceral line and the parietal pleura together in a normal patient, and if you're breathing, then there's motion at that interface when you breathe. If your lung has collapsed, there won't be any motion at that interface because the lung is way down here. There's 3 big things you're going to look for with a pneumothorax. One is the pleural line. We just talked about that. The other is lung sliding. And the last is when you can put an M-mode line through the pleural line, put the image in M-mode and watch over several respiratory cycles what happens through that line, and you can actually see whether the lung is moving underneath due to an artifact that it creates on the M-mode. We have several examples of that. So again, your anatomy, identify your pleural line. Remember that you have the ribs, which also hyperechoic at the cortex, and there's usually rib shadows behind the ribs. Some people call this the bat sign, so that you have the cortex of one rib and the cortex of the other rib is the wings and the pleural line is the body. You can kind of see that. You're looking for that. That's what you want to see in your image. The rib on either side and the pleural line in the middle. You may see A lines. If you do, does that mean you don't have a pneumothorax? No, because A means air. Doesn't necessarily mean the air is inside the lung, it could be outside. You may see B lines if the patient has pulmonary edema. If you see B lines, do you think that the patient has a pneumothorax? Right. If you see B lines, the patient does not have a pneumothorax because B lines are originating from the interstitial edema that's from the lung. And so if you have lung in the field and it's up at the chest wall, then your lung is not collapsed by definition. So we'll show you some pictures of that. When you have a pneumothorax, this interface is obliterated. Essentially, you will have the parietal pleural line, but you will not see the motion of the visceral at the parietal line. Okay, so again, you use your high-frequency probe. You place it in a craniocaudal orientation, sagittal orientation, starting at the second intercostal space, using mid-clavicular line. You watch through several modes of breathing, and you get this image in your picture, the pleural interface and the 2 ribs, and you're looking for the lung to slide back and forth as you breathe. And remember that the lung goes craniocaudal, so the best orientation to really catch it is when you're in the vertical orientation. So remember that air impairs transmission of sound. So when the lung is up, you will see sometimes very faint B lines, you'll see A lines, but you won't see deep into the lung unless the lung is consolidated or something wrong with the lung. But you can see the pleural interface. You should be able to see that. You should be able to see sliding. However, if the lung has collapsed, that lung drops away, and you will not be able to get your ultrasound beam through that pocket of air to see anything underneath, including B lines. So even if the patient has pulmonary edema, you're not going to see it because there's air that's going to get in the way of your image. Everybody appreciate that? Why it would be hard to see, and you wouldn't see the sliding. Okay, some examples. This patient is breathing. You can see a rib shadow on either side. You can see the pleural line, and you see some probably normal B lines, just very faint ones. But you can appreciate that there's movement at that interface. Okay, rib shadow, ribs and rib shadows. And again, just in case we're not talking the same language, this is lung sliding and with some B lines underneath. This means that your lung is up. It's basically the visceral and parietal pleura are touching each other, and you don't have a pneumothorax in that area where you're looking. Doesn't mean you don't have a pneumothorax somewhere else. You still have to be thorough and look at all the 8 quadrants, but it means at the place where you're looking, the lung is adhered to the chest wall. Okay. Pneumothorax, however, this patient is breathing, not holding their breath. So you do see some movement of the chest wall because the patient's intercostal muscles are still contracting, but as far as the sliding, you don't see anything anymore. Sliding appears to a lot of people, it's been described as marching ants or shimmering. So what you're looking for is, it looks like little tiny ants are marching along that line, or that there's a shimmery effect. And if you don't see that, then you have to be concerned that the lung is not touching the chest wall. And then you can also appreciate there's no comet tail there, and there may even be the hint of an A-line there at the bottom of the screen. Okay. All right. Moving on. Just a couple examples. Is this lung sliding? So, pneumothorax or not? No. Good. You're experts now. That's really all you need to know.
How difficult is it to get that image?
Very easy to get the image. You will all be flying through this and then looking at kidneys and hearts later today, because it's very easy to get the image. Okay, so we're moving on to the M mode. So if you put an M mode line through that interface, through the pleural line, and watch it over time, you end up having an image that we call Sky Ocean Beach. You'll hear it also referred to as the seashore sign. Either way, the soft tissue creates a striped appearance. The pleural line is bright white, and that's kind of like where the ocean meets the land. And if the lung is sliding underneath that pleural line, you get a grainy effect due to the motion. You can't see the lung itself, but you can see the motion artifact. So basically that graininess is the beach, and that means the lung is moving, and it's in the picture. So that Sky Ocean Beach is normal. If the lung has dropped, the beach disappears, because you just basically have stripes the whole way down, because all you're getting are reverberations from the soft tissue. You can't see any lung, you can't see motion of the lung, so the beach drops out of the picture, and you have a barcode or stratosphere sign. Okay, some examples. This is a M mode through the pleural interface with, you can also appreciate, even though it hasn't gotten all the way across the screen, that you have very definite sky, ocean, with the pleural line being the horizon of where the ocean meets the land, and a beach, more inferiorly. That's due to the motion of the lung. Okay? And by contrast, we have an upper picture where you can appreciate an A line, which tells you could be pneumothorax, could be normal, but then when you put an M mode through it, you have no beach. And this is a pneumothorax. It looks like a barcode. So this is what we're looking for. In your models today, I'm sure nobody's going to have a pneumothorax, but if you ask them to hold their breath very carefully, like when you're doing an M mode, get Sky Ocean Beach first, but then ask them to hold their breath and really, ask them not to move at all, and you'll be able to see the stratosphere sign, the barcode. Because if the lung's not moving, you won't get that graininess. Sky Ocean Beach. Nope, pneumothorax. Good job. Okay. Good job. Okay. Just another example of, on the lower picture, a film with multiple A lines, and when you put the M mode through it, you have what definitely looks like a barcode, and the above picture where you can see the beach, the graininess of the beach due to lung motion. And which one is positive? Right or left? Correct. It's very, once you understand what you're looking for and you can find that image, not a problem. And last example, which one is positive? Left. Nice job. So you can see how this, instead of ordering a chest x-ray, waiting for the tech to come up, getting a film, waiting for someone to read it, 30 minutes later you get your answer. You can see how just putting a probe on the chest, you get your answer in 30 seconds, and you can really benefit the patient by knowing what's going on. Okay. One last thing I'm going to mention that's very specific to pneumothorax, and actually is 100% diagnostic if you see it, although you may go your whole career and never see it. If you do, I want you to understand what it is you're looking at. It's something called a lung point. A lung point is literally the point at which the lung drops away from the chest wall. So if you get that rib space, where you have a rib on one side, a rib on the other, and the pleural line, if you get in that rib space where as the patient breathes, you can see sometimes the lung is up against the wall, and sometimes it's not, because the lung's moving and it's pulling that dropped away area into the picture, you will have, in the same picture, as the patient breathes, you'll have a lung point. This is the point where it drops, and on this side you have no slide and A lines periodically, and on the other side you have sliding sign and comet tails, because this is where the actual point at which the lung falls away from the chest wall. 100% diagnostic. If you see this, this is a pneumothorax. Nothing else does this. Can everybody see that? Mm-hmm. And if you look at it from a CT point of view, if you're looking at this exact spot where the lung has fallen away from the chest wall, you can imagine you put an M mode through there, and sometimes you might see the lung up and sometimes you might see it down as the patient breathes. Okay. One caution before we move on, there are other things that can cause lack of sliding. So you also want to look at the clinical picture, look at the M mode and so forth. Sliding is not the only thing you want to look for. You want to look for B lines, A lines, and so forth, and really take a full view before you make a decision, because if a patient has a chest tube in, for instance, that's tacking down their lung won't slide when they're breathing. Or if they have a bleb or adhesions from a prior infection or anything like that, sometimes the lung does not slide normally. But you would still be able to see B lines, you would still be able to see that a little bit of motion when you go on M mode, you would still be able to see that. Sciatica beach should still be there. But lack of sliding, be careful. If you see lack of sliding, don't make your diagnosis just on that. Okay? All right, we're going to move on to fluid. So now we've talked about air in the wrong area, air in the pleural space. We're going to talk about fluid in the pleural space and what that appears to be. So the best place to look for fluid is at the diaphragm on either side. So fluid is dependent. A patient is supine. The fluid's going to be falling into the costophrenic recess, the angle right there. So if you put your probe with the indicator towards the patient's head, right about where you think their diaphragm would be, you can identify, and everybody in here knows what the liver looks like, and the diaphragm is bright white right above the liver. The area right cranial to that, or towards the head, is the pleural space, and that's where we're going to be looking. So you can imagine, with the dot towards the patient's head, you have liver, diaphragm, pretty clear, and right above that, if you see blackness, what is black? What turns out black in ultrasound? Fluid. Right. What does air look like in ultrasound? Air doesn't look white. Air, you can't see air. Air just scatters the picture, right? Air doesn't conduct ultrasound well. So basically, if you have air, I'll show you what happens when you have air in just a moment, you get a different kind of picture. This is the space, again, where you're placing your probe. You're finding the liver, you're moving up and down so you can find that person's diaphragm, and this area is where you want to image. People's diaphragms are in different places. People don't necessarily read the textbooks. COPDers have very low diaphragms because their lungs are hyperinflated. Some people have great big livers and their diaphragms are up in their armpits. So you need to look around and find out where their diaphragm is. Don't just assume. So here's a good example of, there's a little picture of Morrison's pouch, kidney, liver, and right above the liver, you see black, which should not be there. That is a pleural effusion, and depending on the situation, it could be pus, blood, transudate fluid. That's more of a clinical diagnosis, but it's definitely fluid in the wrong place. By contrast, if you don't have fluid there, what happens to the air is it comes down through the liver, bounces off the diaphragm, reverberates a little bit, comes back to the probe, and the probe interprets that there's liver deeper than there is. So it looks like you have a liver on the other side of the diaphragm, or on the other side it could be the spleen. So this is what we call the mirror sign. So if you have a mirror image of the liver on the other side of the diaphragm, or a mirror image of the spleen on the other side of the diaphragm, that means that there was air there at that interface, that normal lung was up at the diaphragm, and that acoustic impedance between the two layers was too great, set up a resonance, and created an artifact of a mirror image. So lack of black is usually air, and that's normal. The other thing I want you to note here is something we call the spine sign. So you can see the vertebral shadows all the way up to the diaphragm, right? And then they disappear. So why do you think that is? Does air conduct ultrasound well? No, because the ultrasound is trying to get through the lung to see that what's behind the lung, and the air will scatter everything, so you're not gonna get a signal from what's behind the lung if there's air. If there's fluid, you'll sometimes, and many times, see the spine continuing further up. Okay, normal or not? Not. And you can almost see that there's some settling of content. This is a hemothorax, so instead of just plain fluid, which would appear all black, there's a grayish kind of layering effect to it, and that's because there's red blood cells in blood, and if they sit there long enough, they will settle out and the plasma comes to the top, so you have this gradient, which appears, what blood appears like. And on the other side, we have the mirror image. That's normal. That's an aerated lung with no fluid. I've mentioned transudative versus exudative effusion in hemothorax. Sometimes you can tell the nature of the effusion, and it guides your management. For instance, if you're thinking about just putting a very thin needle into effusion to drain it in a thoracentesis, you might not choose to do that if you have something that looks very thick with fibrinous loculations or blood in it, because you need to manage those differently. So it does help. It's not diagnostic. You should never say this is transudate versus exudate based on what the ultrasound looks like. Because you need to send it to the lab to be sure, but you can pretty much tell when you look at it if you're going to need a needle or a chest tube to drain it. So it's very helpful for that. Notice on that bottom right image of the transudate, you can see the spine shadow behind that fluid. You see the spine sign? Okay. We also use the probe in real time with a sterile glove or a sterile cover on it to guide procedures. Many times people will just mark it with an X and then reposition the patient in about the same position and hope for the best. But I think if you've got the ultrasound available to you, it's best to use it in real time, because look at all the vital organs that are pretty close to where you're going to be putting a pretty large bore needle. So unless you really want to get a spleen or a liver biopsy, it's probably a good idea if you have the ultrasound to use the ultrasound while you're doing the procedure to guide. You can actually see the needle going into the fluid, know when to stop pushing. Just gives you an idea. Okay.
Okay. See my needle.
From the fluid and air.
All right, we got your needle. Your needle.
This is not used as commonly in the ICU, but it's becoming more popular. Like I said, the European groups, Liechtenstein and so forth, use chest X-ray almost exclusively to diagnose consolidation. Use ultrasound almost exclusively, and chest X-ray is less popular. So pneumonia on a chest X-ray looks like patchy, multilobar, sometimes infiltrates. You don't know what the infiltrates are. You can't say it's infection. It could be blood, contusion, tumor, but you have an infiltrate. And what is common amongst all infiltrates is that whatever is in the lung is replacing the air. So you can imagine that those normal air artifacts are going to be changed when you have pneumonia or consolidation in the lung. So the other substance, whether it's fluid, pus, solid tumor, will allow the ultrasound waves to go deeper into the thorax, and you're going to see more of the lung itself. And inside the lung tissue, things have different echogenic properties. For instance, the bronchi have more connective tissue in them, so you're going to see brighter white lines for bronchi. If the lung is severely consolidated, it will actually end up looking like liver. We call that hepatization of the lung, which is just a term meaning it's really socked in. Pneumonia, it almost looks like a solid organ, and those patients are generally in pretty serious trouble. Some examples of what it can look like. So if you image into the lung, and instead of seeing A lines or B lines, you see something that looks like a little bit like liver with bright white horizontal lines going through it, then that is lung with air bronchi, or with bronchograms, basically. The bright white is the connective tissue of the bronchi. You're able to see them because solid has replaced air, and you're able to actually image the lung in these circumstances. Some other examples, a still picture. This is at the costophrenic recess. You can see the diaphragm all the way to the right of the picture, the lingula of the lung, the pointy area of the lung. The lung is fairly socked in, so it looks solid. You can actually see it. And the fluid around it, which is probably a parapneumonic effusion or an empyema. And even when you use the higher frequency probe and you don't get that much of a picture of the lung, you can appreciate in that even just in the 2 centimeters of lung you can see of the high frequency probe, it looks gray, doesn't look black, and that's a consolidation. Again, normal lung, A lines, you don't really see the lung itself, you see the artifact as opposed to pneumonia, where you can see the lung, the bronchi, and it almost looks like a solid organ. So if you go in all 8 of your quadrants, basically, quadrant on both sides, you might be able to even say this is a right upper lobe infiltrate and compare that with your chest x-ray, because not everybody has full, and it's a good thing, not everybody has full pneumonia on both sides. You might have one lobe affected on either side, and you can start to hone your skills by trying to find it and then comparing it to the chest x-ray. And here's a good example of a bronchogram. So if you have fluid in the bronchi, the fluid appears black, but the walls of the bronchi appear bright white, and you can actually see the outline of the bronchi. And fluid is usually inflammatory or white cells. And lastly, I'll mention that if you put Doppler on a consolidated lung, it tends to be more hypervascular, but it's hard. There's not a definitive number we're looking for. It's just if you compare it to a non-consolidated part of the lung, there's more vascularity to a pneumonia. Other things we can see are abscesses, very discrete collections of fluid within the lung. This is an example of a lung abscess after significant necrotizing pneumonia. Here's another great example of, you can actually see the outline of the entire bronchus through ultrasound because the lung is so consolidated. Okay, we're going to wrap up. We're going to remind you that you want to scan all areas of the chest. If you are to look for comet tails, you want to look for them in diffusely, multiple, going all the way to the edge of the screen. You will not likely see them in our normal models today, but if you want to see them, join us in the ICU any day. And you want to look for, with pulmonary edema, you're expecting bilateral positivity. The stars represent the rib shadows. The pleural line is where the arrows are, and just another example of what comet tails look like. Reminder that the comet tails are an artifact. But just because there's resonance set up at that interface between air and water, that sound wave just reverberates infinitely and creates this vertical artifact. And pneumothorax, a reminder before we go to our models, that sky ocean beach and sliding is what we're looking for in a normal lung. Lack of sliding and barcode, and definitely lack of B lines, what we expect to see in the pneumothorax. So when you go to your scanning today, it won't take you, you'll all become experts within about 10 minutes. It won't take you long. You want to make sure you identify, you use your high frequency probe, you identify rib shadows in the pleural line, watch through several cycles of breathing, put an M-mode line through the pleural line, ask your model to hold the breath, ask them to breathe and see how it looks different, so you can see sky ocean beach and barcode. And then with whatever time, do it also with the P21 probe. The P21 probe is a cardiac probe. You can see deeper, and you're not going to, the pleural line's going to be way at the top of the screen, so it's not going to give you the detail, but it gives you also an idea of whether any B lines are better seen with the P21 probe. So go back and forth between probes, but pneumothorax, you definitely want to use the high frequency probe. And with what time you have left, practice your views of that pleural space. Look for fluid in the pleural space, Morrison's pouch, splenorenal recess, and anything else that you feel like you need to review, because you'll have extra time today. Any questions?